Your blood pressure number is not a diagnosis. It's a receipt, a printout of everything that's been happening inside your artery walls, quietly, invisibly, for years. The number tells you the damage is done. It tells you nothing about what caused it, where it started, or how to actually reverse it. Most people have been carrying that receipt for a decade, taking medication, watching SALT, going to checkups, and nobody has ever read it with them, line by line, cause by cause. That ends today, because that receipt has exactly 4 lines, 4 biological processes driving your blood pressure upward long before any cuff caught it. I'm Dr. Marcus Adebayo. I've been practicing cardiology and internal medicine for over 25 years. What I'm about to show you is not alternative medicine. It's the biology that standard treatment simply doesn't have time to address. Stay with me. This is the conversation your receipt has been waiting for. Let me give you an analogy that changed how one of my longtime patients thought about his blood pressure. He'd been on medication for 8 years, good compliance, never missed a dose, and yet every 6 months his numbers crept higher, the dose got adjusted, and he left feeling like he was losing ground on a battle he didn't fully understand. I told him, imagine your body has been sending you a series of urgent messages for years. Your artery walls are the messenger. The message is, something is wrong at the structural level. Please address it. The medication hears that message and turns down the volume. The number drops, the alarm quiets, and everyone assumes the problem is solved. But the messenger is still there, still sending the signal, because the underlying problem, the thing that triggered the alarm, hasn't been touched. That's not a failure of medication. Medication is doing exactly what it was designed to do. The failure is in assuming that silencing the alarm is the same as fixing what triggered it. Modern cardiovascular science, research from the last 15 years specifically, has identified 4 distinct biological mechanisms that drive blood pressure elevation in adults over 60. The first line on your receipt is your Glycocalyx, the microscopic protective coating inside your blood vessels. When it erodes, vessel walls become inflamed and reactive. The second line is arterial calcification. Calcium that should reinforce your bones is instead hardening your artery walls, making them rigid and unable to manage pressure. The third line is nitric oxide. Your arteries produce this molecule continuously. It signals vessel walls to relax and open. After 60, that production drops sharply. The fourth line is the insulin-kidney connection. Chronically elevated insulin sends your kidneys a persistent signal to hold on to sodium, more fluid, higher pressure. 4 lines, 4 causes, 4 entry points for real change. And once you understand what each line means, you know exactly what to do about it. The inside of a healthy blood vessel is not bare. It's not just a smooth tube. It has a living, dynamic, biologically active surface that most people have never heard of. It's called the Glycocalyx. Picture it as a forest of microscopic filaments, a dense gel-like mesh lining every vessel in your body from the inside. When that mesh is intact, blood moves through your arteries like a river through a well-maintained channel, smooth, regulated, without friction or turbulence. The Glycocalyx prevents blood cells from sticking to vessel walls. It acts as a pressure sensor. It buffers vessel walls from the mechanical stress of every heartbeat. In short, the Glycocalyx is not a passive lining. It is an active participant in keeping your cardiovascular system stable. And in most people over 60, it has been quietly thinning for years. Here's the mechanism. Blood glucose, the sugar circulating after you eat, becomes physically corrosive to the Glycocalyx above a certain concentration, not at diabetic levels, at levels millions of non-diabetic people reach routinely, multiple times per day. The spike from oatmeal with honey, a glass of apple juice, a couple of crackers with jam. Published cardiovascular research has documented that glucose elevations above a specific threshold begin degrading Glycocalyx components within hours of exposure. Each spike removes a little more of that protective mesh. Each recovery allows partial repair, but repair that never quite catches up with the damage rate. Over decades, the net result is a Glycocalyx substantially thinner than it should be. What happens then? The bare vessel wall beneath becomes exposed to direct blood flow. It becomes inflamed. It triggers an injury response, increasing local pressure, stiffening surrounding tissue. Your blood pressure rises not because your body is malfunctioning. It rises because your body is responding correctly to a signal of vascular injury, a signal caused by something happening 3 times a day at your kitchen table. The glycocalyx regenerates. It is not scar tissue. It is not permanent damage. But regeneration requires 2 things: removing what's damaging it and providing what rebuilds it. Removing what damages it means reducing refined carbohydrates, white flour products, processed cereals, sweetened beverages, fruit juices. These drive the rapid glucose spikes that most damage this layer. Providing what rebuilds it means polyphenols, concentrated in dark berries, pomegranate, extra virgin olive oil, green tea, dark leafy greens. These directly support glycocalyx repair mechanisms at the endothelial surface. There is also a third option, fucoidan, extracted from brown seaweed, showing direct glycocalyx supportive properties in cardiovascular research. Available in supplement form and increasingly included in vascular health protocols. My practical recommendation: do not try to change everything at once. Start with the morning. What are you eating within the first 2 hours of waking? If it involves processed grains or sweetened anything, that is your first target. Replace it. Add the berries. I want to tell you about a delivery problem. Your body manages calcium with extraordinary precision, or at least it's designed to. Calcium is supposed to go to your bones. What keeps it out of your arteries is a specific protein called matrix glicoprotein, MGP. Think of MGP as a calcium interceptor, catching calcium before it reaches arterial tissue and rerouting it toward bone where it belongs. But MGP only works when it's activated, and that activation requires a biological switch, vitamin K2, specifically a form called MK7. Without sufficient K2, MGP doesn't get activated. The interceptor is off duty. Calcium drifts. It enters the arterial wall. Over months and years, it hardens tissue that should be elastic into something that behaves more like calcified bone. I want you to understand physically what this does to your blood pressure. Your heart beats approximately 100,000 times per day. With each beat, healthy arteries expand slightly, absorbing the ejection force, buffering the pressure wave, then recoiling. This elastic behavior keeps peak systolic pressure within normal range. When arteries calcify and stiffen, that buffering disappears. The pressure wave from each heartbeat transmits directly and forcefully throughout the vascular tree. Your systolic number climbs. Your heart works harder with every single beat. No blood pressure medication addresses arterial stiffness directly, not one. They manage the downstream consequences. They don't touch the calcification itself. The Rotterdam Heart Study, a landmark European cardiovascular study following thousands of participants over many years, found a striking association between dietary K2 intake and both lower arterial calcification and lower cardiovascular mortality. The association was specific to K2, not K1, the form abundant in leafy greens that most people assume covers their needs. K2 and K1 are metabolically distinct. They do different jobs. And K2 is essentially absent from the typical Western diet in therapeutic amounts. Alongside K2, magnesium. The smooth muscle cells lining your artery walls contract and relax to regulate vessel diameter. Calcium drives contraction. Magnesium drives relaxation. They are physiological opponents at the cellular level, and the ratio between them inside smooth muscle cells is one of the primary determinants of baseline arterial tone. When magnesium is deficient, which population studies suggest affects 60 to 70% of older adults, the balance tips toward calcium dominance. Vessels stay contracted. Baseline pressure rises. A meta-analysis of over 30 randomized controlled trials found magnesium supplementation produced consistent and clinically meaningful reductions in both systolic and diastolic blood pressure. Best dietary sources: pumpkin seeds, Brazil nuts, dark chocolate, spinach, black beans. For supplementation, magnesium glycinate. Well absorbed, gentle on digestion, effective at restoring tissue levels. The complete protocol for this line: K2-MK7 to activate the calcium routing system, magnesium glycinate to restore the relaxation balance, vitamin D3 alongside both, working synergistically with K2 and calcium metabolism. Remove K2 and the calcium routing fails. Remove magnesium and the arterial walls can't relax. Remove D3 and the whole regulatory framework loses coherence. Together they address something no prescription pad currently reaches. Every system in your body runs on communication. And your blood vessels have their own dedicated signaling molecule whose entire function is to carry one critical message to arterial smooth muscle cells. That message is, relax. The molecule is nitric oxide. 3 researchers shared the Nobel Prize in Physiology or Medicine in 1998 specifically for identifying that blood vessels produce this gas. The endothelium, the single-cell thick inner lining of your arteries, produces nitric oxide continuously. It diffuses through the vessel wall, reaches the smooth muscle layer, and those cells receive the signal and relax. The vessel widens, blood flows with less resistance, pressure drops, automatically, constantly. This happens thousands of times per day in a healthy cardiovascular system. After 60, the signal fades. Production declines in a pattern that becomes clinically significant for most people between their late 50s and mid-60s. The first accelerator of this decline surprises my patients every time. Antibacterial mouthwash, used twice daily, eliminates bacteria in your mouth that play an active role in the nitric oxide production pathway. These bacteria convert dietary nitrates into nitric oxide precursors. Twice daily antibacterial mouthwash eliminates a significant portion of them. Most people are unknowingly suppressing a key cardiovascular molecule every morning and evening in their own bathroom. The second accelerator is mouth breathing. Your nasal passages produce nitric oxide directly, delivering it into your airways with every nasal breath. Chronic mouth breathing bypasses this production pathway entirely. The third is physical inactivity. Shear stress, the mechanical force of blood moving against vessel walls, is a primary trigger for endothelial nitric oxide production. When movement is minimal, that trigger is absent. Now, the 8-minute intervention with clinical backing. It's called isometric hand grip exercise. And when I first encountered the research, I was skeptical. It sounded too simple. You squeeze a hand grip device or a firmly rolled towel at approximately 30% of your maximum capacity, not straining, a firm, sustained contraction. Hold 2 minutes, rest 2 minutes, repeat 4 times. 3 sessions per week. Sustained isometric contraction creates a specific pattern of blood flow change, a particularly potent trigger for endothelial nitric oxide release. With consistent repetition, the endothelium becomes more responsive. A systematic review under the auspices of the American Heart Association found average reductions in systolic blood pressure of approximately 8 to 10 millimeters of mercury from isometric hand grip training alone. For patients over 60, particularly those with mobility limitations, this is genuinely transformative. You need a chair and something firm to squeeze. That is the complete equipment list. Second input, breathe through your nose. Research demonstrates nasal breathing increases circulating nitric oxide by several 100% compared to mouth breathing. Not modestly, several 100%. From a habit change that costs nothing. Third, eat nitrate-rich vegetables. Beetroot is the most concentrated source. Spinach, rocket, celery, and watercress follow. Your body converts these nitrates into nitric oxide precursors through exactly the oral bacteria pathway, which is why reconsidering antibacterial mouthwash matters more than most people realize. 3 inputs targeting the same communication failure. Your vessels have not forgotten how to relax. They've simply stopped receiving the signal that tells them to. I want to reframe something you have probably been told incorrectly for years. Sodium causes high blood pressure. That's the version most people have heard. Cut the salt. Read the labels. Avoid processed food. While none of that is wrong exactly, it is profoundly incomplete. It addresses only one half of the sodium equation. Here is the half nobody explains. Your kidneys don't just passively filter sodium. They actively regulate it, and that regulation is under hormonal control, specifically under the control of insulin. When insulin levels are chronically elevated, the kidneys receive a sustained instruction: hold on to sodium. Don't release it. Conserve it. The kidneys comply. Sodium stays. Water follows. Blood volume increases. Pressure rises. Predictably, mechanically, every single time. This is why so many patients come to me frustrated. They have genuinely reduced salt intake, reading every label, choosing low sodium options, and blood pressure is still elevated. Because the problem was never how much sodium was coming in. The problem is that kidneys are refusing to let the sodium that's already there go out. Insulin resistance doesn't develop overnight. It is the accumulated result of years of frequent carbohydrate-heavy meals producing repeated insulin spikes throughout the day, every day, for decades. Over time, cells become progressively less sensitive to insulin's signal. The pancreas compensates by producing more. Circulating insulin levels rise, telling kidneys, around the clock, to hold on to sodium. After 60, this is compounded by muscle loss. Skeletal muscle is the body's largest consumer of glucose. Less muscle means glucose clears more slowly. Insulin stays elevated longer after each meal. The kidney signal intensifies. The result is a hypertensive pattern genuinely unresponsive to sodium restriction, because sodium intake was never the primary driver. The first intervention, time-restricted eating, food consumption limited to an 8-hour window each day, 16 hours of fasting between last meal and first meal of the next day. During those 16 fasting hours, insulin falls. The persistent kidney signal weakens. Sodium begins to be released. Fluid balance shifts. Blood pressure responds. A study published in Cell Metabolism demonstrated meaningful blood pressure reduction from time-restricted eating alone, without participants changing what they ate or how many calories. Just the timing of meals. Practical entry point. If you currently eat between 7 in the morning and 8 at night, try shifting to 10 in the morning until 6 in the evening. A 16-8 pattern. No special foods, no calorie counting, just a timing shift. If your medications require food or you have any history of hypoglycemia, please discuss this with your physician specifically before implementing. A powerful tool that requires appropriate context. The second intervention is resistance training. Every time a muscle contracts under load, it pulls glucose from the bloodstream through a pathway that operates independently of insulin. The glucose enters the muscle cell without requiring an insulin signal. This directly lowers demand for insulin to clear blood sugar, which over time lowers baseline circulating insulin, which weakens the sodium retention signal. 2 to 3 sessions per week. Resistance bands, light dumbbells, bodyweight exercises targeting large muscle groups. Produces measurable improvements in insulin sensitivity within 3 to 4 weeks. I want to go back to the receipt analogy, because there's something important about how these 4 lines relate to each other that changes everything about how you approach them. Most people want to prioritize. Which line is most important? Which do I fix first? But that instinct is based on a misunderstanding. These 4 are not separate problems. They are 4 entries in a single feedback loop. Glycocalyx erosion causes vascular inflammation. Chronic vascular inflammation accelerates calcium deposition because calcium is part of the body's repair toolkit and inflamed tissue attracts it. Calcified walls become less capable of producing nitric oxide. Endothelial cells in rigid tissue function less efficiently. Declining nitric oxide activates the sympathetic nervous system, one of the most potent drivers of insulin resistance known to cardiovascular science. Insulin resistance elevates baseline insulin. Elevated insulin tells kidneys to retain sodium. Higher pressure increases mechanical stress on vessel walls. Stress accelerates glycocalyx erosion. The circle completes. But here's the other side of that loop. Every intervention anywhere in the circuit creates positive effects everywhere else. Restore the glycocalyx. Inflammation falls and calcium deposition slows. Improve calcium routing. Arteries regain elasticity and nitric oxide production improves. Boost nitric oxide. Sympathetic drive decreases and insulin sensitivity recovers. Lower insulin. Kidneys release sodium. Pressure drops. Glycocalyx repair accelerates. Nitric oxide is the fastest responder. Measurable changes within 2 to 3 weeks of grip training and nasal breathing. Insulin and kidney dynamics shift at 2 to 4 weeks. Glycocalyx regeneration requires 3 to 6 months. This is a repair process proportional to damage accumulated over decades. Treat it accordingly. You will not feel this happening day by day, but at 3 months, at 6 months, the vessel wall is measurably different from what it was. Let me address the question forming in your mind right now. If these 4 mechanisms are the real cause, why am I taking a pill that doesn't address any of them? It's a fair question, and it deserves a direct answer. Your medication is doing something essential right now, maintaining your blood pressure within a range that protects your brain from hemorrhagic stroke, your kidneys from hypertensive damage, your heart from additional workload. That protection is real and it matters. Removing it prematurely, before the underlying mechanisms have been meaningfully addressed, exposes you to risks that are serious and sometimes irreversible. What these 4 steps are designed to do is work beneath that protective layer, to address the biology that your medication cannot reach. Over time, as the glycocalyx rebuilds, as arterial flexibility improves, as nitric oxide production recovers, as insulin normalizes and kidneys begin releasing sodium freely, blood pressure begins to fall from the source rather than being suppressed from above. For some patients, this eventually makes a medication reduction conversation appropriate. That is a real outcome. It happens. But it happens in a doctor's office, with data, a blood pressure log showing consistent improvement over months, blood work reflecting metabolic change. One specific note worth emphasizing: vitamin K2 MK7 interacts with certain anticoagulant medications, warfarin specifically, in ways requiring medical supervision. If you are on any blood-thinning medication, please discuss K2 supplementation with your physician before starting. You have spent years managing a number. It is time to understand what that number is trying to tell you and respond to the actual message, not just turn down the volume. I want to tell you what I actually see when I look at a blood pressure reading, not the number, not the risk category, not the medication adjustment it implies. I see a timeline, a compressed record of what has been happening inside someone's arterial walls, sometimes for 20, sometimes for 30 years. I see the morning breakfasts that spike blood sugar 100 times a year for 2 decades. I see a glycocalyx that was never given the materials to repair itself. I see calcium that traveled to the wrong address because no one knew to activate the protein that redirects it. I see nitric oxide production declining year by year while vessel walls grew progressively less elastic. I see kidneys that have been receiving a sodium retention instruction so continuously, they've essentially forgotten they were ever designed to release it freely. I see all of that in a single number. And what strikes me every single time is not how much damage has accumulated, it is how much of it was preventable. And more importantly, how much of it is still reversible. The human cardiovascular system is not fragile. It is extraordinarily resilient. It has been absorbing insults and compensating and attempting to repair itself for your entire life, often without any support, often against considerable odds. What it needs from you is not perfection, not a perfect diet or a perfect exercise regimen. What it needs is direction. Consistent, informed, biologically coherent direction, pointed toward the 4 mechanisms that have been driving the damage all along. The receipt has 4 lines. You now know what each one means. You now know what addresses each one. That is not a small thing. That is everything. Let's read that receipt one final time, together, line by line, because this time you know exactly what it says. Line 1, your glycocalyx. Reduce refined carbohydrates, add dark berries and leafy greens daily. Consider fucoidan for targeted vascular support. Line 2, arterial calcification. K2 MK7 daily to activate MGP. Magnesium glycinate to restore arterial relaxation. Vitamin D3 to coordinate the entire calcium management system. Line 3, nitric oxide. Isometric hand grip training, 3 sessions weekly. Nasal breathing as a consistent daily practice. Nitrate-rich vegetables, beetroot, spinach, rocket, regularly on your plate. Line 4, the insulin kidney override. Time-restricted eating within an 8-hour window daily. Resistance training 2 to 3 times per week to rebuild the muscle that resets insulin sensitivity at its source. 4 lines, 4 actions, 1 biological system that, when all 4 are addressed together, begin shifting in a direction your medication alone has never been able to create. Which line surprised you most? Which one made something click that hadn't clicked before in all the years you've been managing this? Tell me in the comments. I read every one. If you know someone on blood pressure medication for years without real answers, please share this with them. Not as a substitute for medical care, as a supplement to it, as the conversation their receipt has been waiting to have. A like if this was useful takes 2 seconds. A subscription means you won't miss what comes next, and there is considerably more to come. Take care of your cardiovascular system. It has been working faithfully since before you drew your first breath. It has been sending you signals through every reading on every cuff for years. Now you know how to read them. Everything I've shared today is grounded in current cardiovascular and metabolic research, reflecting my clinical perspective after 25 years of practice. But it is general medical information, not personalized advice for your specific situation, your specific medications, or your specific history. Before making any changes to your treatment plan, please have a direct conversation with your own physician. Bring this information with you. Ask the questions. Push for the answers. That's not a disclaimer. That's just what good medicine actually looks like.